So hello and welcome to today's Healthy People 2030 webinar. My name is Carter Blakey. I'm the Deputy Director of the Office of Disease Prevention and Health Promotion at the U.S. Department of Health and Human Services. And ODPHP is the office where the Healthy People Initiative lives. Next slide, please. So before we begin, I'll note that the speakers in today's webinar have no commercial relationships or conflicts to disclose. Next slide, please. And I'm also pleased to announce that today's webinar attendees can submit for select continuing education hours. Next slide. So following the webinar, participants will receive an email from CPD@Confex with instructions on how to obtain continuing education credit and a certificate. So now with the next slide, we will turn to the series today. So those of you who are new to our webinar series, each year Healthy People hosts quarterly webinars that feature the latest data on select Healthy People 2030 objectives. So the webinars cover important public health topics and features that states, communities, organizations, and others are working on to achieve the Healthy People 2030 targets through implementation of evidence-based interventions, programs, and policies. So I invite you to join our Healthy People listserv to receive real-time information on the dates and the themes of upcoming webinars. Next slide, please. So today's webinar is titled Substance Misuse Prevention Strategies to Improve Public Health, a focus on state practices. So substance misuse is a serious public health challenge. It includes the use of illegal drugs, the inappropriate use of legal substances such as alcohol and tobacco, and prolonged repeated use of substances at high doses or high frequencies can, in some cases, also lead to what's called substance use disorder. So substance use disorder, or SUD, is a treatable mental disorder that affects a person's brain, behavior, leading to their inability to control their use of substances like legal or illegal drugs, alcohol, or medications. So in 2021, 46.3 million people aged 12 or older, or 16.5% of the population, had substance use disorder in the past year, including 29.5 million who had an alcohol use disorder and 24 million who had a drug use disorder. So the prevalence of substance use disorders highlights the need to prevent drug and alcohol misuse and to help people with substance use disorders get the treatment that they need. Substance use disorders can involve illicit drugs, prescription drugs, or alcohol. Opioid use disorders have become especially problematic in recent years and will be the topic covered during our webinar today. So before we hear more about substance misuse and strategies for prevention, let me introduce our speakers for today. So we'll hear first from Rear Admiral Paul Reed, who is the Director of the Office of Disease Prevention and Health Promotion, and he'll address the importance of the 3 Healthy People 2030 objectives that will be featured today. Then next, we'll hear from Commander David Wong, who is the Branch Chief of the National Center for Health Statistics, Health Promotion Statistics Branch. So David will provide details on current progress toward meeting the objective targets and review differences observed across population groups for the 3 featured Healthy People 2030 objectives. Then lastly, Zahra Al-Ali, a research scientist and prevention agenda coordinator of the New York State's Health Improvement Plan, will discuss New York State's activities related to one of the plan's focus areas, and that's substance use prevention. And following these presentations, we'll have a moderated Q&A with these speakers, as well as representatives from the Healthy People 2030 topic areas of medical product safety and substance use work group. So during the entire webinar, we encourage you to submit questions into the Q&A feature, which is located in the bottom of your screen. And throughout today's presentations, please do that, and we will do our best to address as many of your questions as time allows. So With that, it's now my pleasure to transition the webinar over to Rear Admiral Paul Reed. So Paul, it's all yours.
All right, thank you, Carter. And thanks to all those of you joining us today from our audience. Really appreciate you being on the webinar. I'm going to begin our discussion, as Carter alluded to, with a brief overview of the Healthy People 2030 objectives featured today. So if I could get that next slide. The 3 Healthy People 2030 core objectives included in today's webinar cover a range of topics related to medical product safety, social determinants of health, and substance use. I'll give an overview of each of these objectives and how they relate to the subject of our webinar, substance misuse, in the upcoming slides. But first, as a little background context for the objectives, it's important to note that Healthy People 2030 work groups made up of federal subject matter experts monitor these objectives throughout the decade, including the science behind them, the relevant data, progress in moving toward targeted outcomes, and resources associated with each of the objectives. And these work groups help ensure Healthy People content is grounded in up-to-date evidence and data, and is valuable to the American public, frankly. Now, the featured objectives in today's webinar include MPS 02, or reduce emergency department visits related to non-medical use of prescription opioids. And this objective is managed by the Medical Product Safety Work Group. The second is SDOH 05, or reduce the proportion of children with a parent or guardian who has served time in jail or prison, which is managed by the Social Determinants of Health Work Group. And SU 11, reduce the proportion of motor vehicle crash deaths that involve a drunk driver, which is managed by the Substance Use Work Group. And these 3 objectives are Healthy People 2030 core objectives, which means they will be tracked throughout the decade, and progress toward achieving their targets will be updated as data becomes available. As core objectives, they are measurable, have specific targets to be achieved by the end of each 10 years. They reflect high priority public health issues and are associated with evidence-based interventions. They have valid, reliable, nationally representative data, including baseline data from no earlier than 2015. And as core objectives, they're expected to have at least 3 data points throughout the decade to assess any trends that you might follow. So next slide. The first objective featured today is focused on prescription opioid use, and specifically MPS 02 assesses emergency department visits related to non-medical use of prescription opioids. As we've all heard over the years recently, increased prescription of opioid medications like oxycodone and hydrocodone, in part, has led to widespread misuse of both prescription and non-prescription opioids. It's well established that improving the way opioids are prescribed through evidence-based clinical practice guidelines can ensure patients have access to safe and effective pain management, while reducing the number of people who potentially misuse or overdose from these drugs. And many medication-related emergency department visits involve non-medical use of prescription opioids, although it should be emphasized that the overall epidemic of narcotic overdoses and related deaths is driven by non-pharmaceutical products such as those containing illicitly manufactured fentanyl. Ensuring equitable access to healthcare and related support services for narcotic use without stigma can promote a pathway toward prevention. One important reference to highlight in this regard: the 2022 CDC Clinical Practice Guideline for prescribing opioids for pain provides recommendations for clinicians providing pain care, including those prescribing opioids, for outpatients aged 18 years and older. I'd also encourage you to visit the Healthy People website to learn how some Healthy People champions successfully work to reduce overall emergency department visits related to opioid overdoses. This cross-sector collaboration is a real-world example of how local communities are addressing this important topic. And examples such as these may help other organizations learn how they might approach similar issues in their respective communities. Next slide. The second objective featured today, SDOH 05, monitored by the Social Determinants of Health Topic Area Work Group, as I mentioned, highlights how relationships and interactions with family, friends, coworkers, and community members can have a major impact on health and well-being. Children of incarcerated parents are more likely to have faced exposure to drug and alcohol abuse in their homes than other children. And childhood exposure to substance abuse and instability due to parental separation is a possible adverse childhood experience that can be harmful to a child's health and well-being. And adverse childhood events are known to be positively correlated with risk of substance use and substance use disorder in adulthood. Creating and sustaining safe, stable, nurturing relationships and environments for all children and families can prevent adverse childhood events and help children reach their full health and well-being potential. Next slide. And the final objective featured in today's webinar is focused on substance misuse while driving. Objective SU11 assesses the percentage of motor vehicle crash deaths that involve a drunk driver. I think it goes without saying that safe driving requires focus, coordination, good judgment, and quick reactions to the environment. And any alcohol or other drug use impairs the ability to drive safely. Notably, almost 1 in 3 traffic deaths in the United States involves a driver with a blood alcohol concentration of 0.08 grams per deciliter or higher. And it's also known that some groups are more at risk for impaired driving and related crashes and deaths. For example, according to the National Highway Traffic Safety Administration, in 2021, there were about 4 male alcohol impaired drivers involved in a fatal car crash for every female alcohol impaired driver. Also, the 21 to 24 and 25 to 34-year-old age groups had the highest percentages, 27% each, of alcohol impaired drivers involved in fatal crashes as compared to other age groups in 2021. Knowing such risk factors for impaired driving can help us tailor strategies that may reduce traffic fatalities. In the Community Guide, a collection of evidence-based recommendations and findings from the Community Preventive Services Task Force, offers a number of interventions related to motor vehicle injury prevention, including reducing alcohol impaired driving. And the CDC has state-specific fact sheets that provide a snapshot of crash deaths involving alcohol impaired drivers and an overview of proven strategies to reduce or prevent alcohol impaired driving. Working across national, state, and local levels, we can implement effective measures that help prevent injuries and deaths from impaired driving. So with that, as a quick overview of today's featured objectives, I'm going to pass the virtual mic and turn it over to David Huang to review the latest data for these 3 featured objectives. Thank you very much. And David, over to you.
Great. Thank you very much, Rear Admiral Reed. Next slide, please. I'm pleased to be here with you today to share national data for 3 Healthy People 2030 objectives chosen to frame our discussion on substance misuse and childhood adversity prevention. As Rear Admiral Reed mentioned in his presentation, the measures I will cover track emergency department visits related to non-medical use of prescription opioids, children with a parent or guardian who has served time in jail or prison, and motor vehicle crash deaths involving a drunk driver. All of the data I will be sharing today are based on a subset of the full complement of information housed on the Healthy People 2030 website. The specific population groups were selected based on input from my colleagues at NCHS, Healthy People subject matter experts, and statistical relevance. Next slide, please. I will begin by discussing emergency department visits related to non-medical use of prescription opioids. Next slide, please. Emergency department, or ED visits, related to non-medical use of prescription opioids are tracked using the National Electronic Injury Surveillance System, Cooperative Adverse Drug Event Surveillance Project. The objective definition includes prescription opioids taken more than prescribed or recreationally. For this objective and the next, the data are collected annually and reported biennially. Combining multiple years of data allows for more reliable estimates, especially for smaller subpopulations. The baseline is 3.9 ED visits per 10,000 in 2016-2017. The national target is 3.5 and was exceeded in 2020-2021. Next slide, please. This slide shows ED visits related to non-medical use of prescription opioids in the total population and by sex for the years 2016-2017 and 2020-2021. Rate comparisons made throughout today's presentation are statistically significant at the 0.05 level, unless otherwise noted. In the total population, the rate decreased between the 2 data points shown here, although the change was not statistically significant. The ED visit rate decreased for males and females, but the change was not statistically significant for males. Comparing the ED visit rate by sex shows that rates were higher for males at both the earlier and later time points. Next slide, please. Here we see ED visits related to non-medical use of prescription opioids in the total population and by age in 2016-2017 and 2020-2021. In the later time period, the rate among adults ages 18 to 44 was 5.1 ED visits per 10,000 population and was more than 3.5 times the rate of the lowest group, which was observed among adults ages 65 and older. During the time shown here, visit rates decreased for people ages 18 to 44, 45 to 64, and 65 and older. But the changes were only statistically significant for ages 45 to 64. The rate for people less than 18 was not statistically reliable in 2020-2021, and therefore is not displayed here. Although the data displayed indicates some improvement in ED visits related to non-medical use of prescription opioids, overall drug overdose death rates and deaths caused by illicit fentanyl continue to rise. For more information, please see the drug use and injury prevention sections of the Healthy People website. Next slide, please. Next, I will discuss children with a parent or guardian who has served time in jail or prison. Next slide, please. This objective tracks children with a parent or guardian who has served time in jail or prison using data from the National Survey of Children's Health, or NSCH. Although surveys were completed by a parent or knowledgeable adult, the data presented are for their children, even when shown by parental demographics. During the 2016-2017 baseline period, 7.7% of children ages 17 and under had ever experienced a parent or guardian serving time in jail or prison. The national target for this objective is 5.2%. The most recent data available show that this objective is improving. And one final note for this objective, although I may use the terms percent and rate interchangeably here, the unit of measurement is a percent rather than a rate. Next slide, please. From 2016-2017 through 2020-2021, the rate of children with a parent or guardian who has served time in jail or prison declined by 15.7%. Next slide, please. This slide shows the rate of children with a parent or guardian who has served time in jail or prison by the child's race and ethnicity in 2020-2021. Throughout this presentation, when discussing race and ethnicity, we'll look at Hispanic ethnicity along with race groups, which exclude persons of Hispanic origin. Among racial ethnic groups, the American Indian Alaska Native population had the highest rate, 18.8%, and Asian children had the lowest rate, 0.6%. Next slide, please. This slide shows the rate of children with a parent or guardian who has served time in jail or prison by the child's sex, age, and special healthcare needs status in 2020-2021. Males, children ages 12 to 17, and children with special healthcare needs were most likely to have experienced a parent or guardian who served time in jail or prison compared to their counterparts. Next slide, please. Here we see the rate of children with a parent or guardian who has served time in jail or prison by health insurance status, family income, and educational attainment. Children who had public health insurance were most likely to have experienced a parent or guardian who has served time in jail or prison compared to their counterparts. Similarly, children and families with incomes below the poverty threshold and those in households where the most highly educated adult had a high school education were also most likely to have experienced a parent or guardian who has served time in jail or prison compared to their counterparts. Next slide, please. Finally, I will talk about motor vehicle crash deaths involving a drunk driver. Next slide, please. Drivers are considered drunk when their blood alcohol concentrations are 0.08 grams per deciliter or higher. a driver is defined as the operator of any motor vehicle, and the drunk driver does not have to be at fault or the decedent. All data presented in this section are for the decedent. The objective is tracked annually using the Fatality Analysis Reporting System, or FARS. The baseline for this objective is 29.0%, and the national target is 28.3%. Based on the most recent data, this objective is getting worse. Since the unit of measurement for this objective is a percent, an increase or decrease in this measure over time does not necessarily imply an increase or decrease in the raw number of deaths. Next slide, please. This slide shows the percentage of motor vehicle crash deaths involving a drunk driver by the sex of the decedent from 2017 through 2021. Although there was a dip in 2019, the total increased from 29.0% in 2017 to 31.2% in 2021. A similar pattern was observed for males and females, with the percentage of males increasing from 31.1% to 32.4%, and the percent of females increasing from 24.0% to 28.0% over the same time period. Next slide, please. Here we show the percentage of motor vehicle crash deaths involving a drunk driver by age for the baseline and the most recent year. In both years, the percentages were highest for people ages 18 to 44 and 45 to 64. For all age groups, the percentages were higher in 2021 than they were in 2017, although the differences for people 18 to 44 were not statistically significant. Next slide, please. This slide shows the percentage of motor vehicle crash deaths involving a drunk driver by race and ethnicity in 2020. Note that I am not showing the 2021 data by race and ethnicity because the 2021 FARS annual report file contains a high proportion of records with unknown Hispanic origin and race. Many of these unknowns should be resolved when the 2021 file is finalized. Among racial ethnic groups, the American Indian Alaska Native population had the highest percentage of motor vehicle crash deaths involving a drunk driver, and the Asian population had the lowest. Next slide, please. I will end by sharing some key takeaways. Next slide, please. ED visits related to non-medical use of prescription opioids met the Healthy People 2030 target for the total population in 2020-2021. Rates generally decreased with age, and males had higher rates than females. Between 2016-2017 and 2020-2021, the percentage of children with a parent or guardian who has served time in jail or prison decreased, but there were differences between groups. In the later period, American Indian Alaska Native children had the highest percentage of children that experienced a parent or guardian who had ever served time in jail or prison, and Asian children had the lowest percentage compared to other racial ethnic groups. Finally, between 2017 and 2021, the percentage of motor vehicle crash deaths involving a drunk driver has increased. The most recent data show that males, people ages 18 to 44, and the American Indian Alaska Native population had the highest percentages compared to their counterparts. Next slide. Before I conclude, I would like to thank the 3 work groups whose objectives were highlighted today, as well as the NCHS and ODPHP staff listed here for their contribution. I'll now turn it over to the next speaker, Zara. Thank you.
Thank you, David, and thank you, ODPHP, for giving us this opportunity to present and share our experience with the prevention agenda with the audience and everyone here. Next slide. So today I will give a quick overview of the prevention agenda, and then I will talk a little bit about the role of stakeholders in the planning and implementation of the prevention agenda. And last, I will discuss key findings, successes, and challenges of the current prevention agenda cycle. Next slide. So each state has a state health improvement plan. It is called also the SHIP. In New York State, we call the SHIP, or the State Health Improvement Plan, as the prevention agenda. And the prevention agenda basically identifies health priorities in New York State and calls for the state and local action to improve the health and well-being of all New Yorkers. So the goal of the prevention agenda is to improve the health status of New Yorkers and also to reduce the health disparities through an increased emphasis on prevention. And the current vision of the prevention agenda is to be the healthiest state in the nation for people of all ages. Next slide. A quick glance at the history of the prevention agenda would be helpful to see the changes across the years and across the cycles. The first cycle of the prevention agenda started in 2008, and it was a 4-year cycle. There were 10 priorities, including access to quality healthcare. New York State was ranked number 28 healthiest state in the nation. Local health departments and hospitals were asked to work together on the assessment and implementation plans during this cycle. However, because of the huge number of priorities and focus area under each priority, this collaborative work deemed challenging for both hospitals and local health departments. Second cycle was between 2013 and 2018. The priorities were limited to 5 with a focus on prevention. New York was the 15th healthiest state in the nation, and local health departments and hospitals strongly urged to work on a combined assessment and implementation plans. During the second cycle, New York State Department of Health provided feedback on the submitted plans and required annual updates to monitor progress. Also, hospitals were asked to report community benefit spending and to link community benefit spending with delivery system reform incentive payment, or what is known as the DSRIP. In the third cycle, which is the current cycle of the prevention agenda, which started in 2019 and will end in 2024, we continued with the 5 priorities identified in the second cycle. New York was ranked number 23rd healthiest state in the nation, and the change in ranking was influenced by adding new measures to account for health disparities. This cycle incorporated the health across all policies approach and age-friendly New York to address social determinants of health and to support the state's commitment to making New York State the first age-friendly state. COVID-19 pandemic, however, was one of the biggest challenges during this cycle. Hospitals and local health departments' priorities were drastically altered by the pandemic. Next slide. The priorities identified for the current prevention agenda are 5. The first one is prevent chronic diseases. Second priority is promote a healthy and safe environment. Third priority is promote healthy women and infants and children. The third or fourth priority is promote well-being and prevent mental and substance use disorder. And the last one is prevent communicable diseases. Each priority area has different focus areas that discuss different public health issues. Next slide, please. In general, each focus area has a specific goal, measurable objectives, evidence-based interventions, resources for implementation, a list of identified population or age groups affected by the public health issue, and a list of organizations or partners that play leading or supporting roles. Next slide. In this slide, we are giving an example of a priority area. We have promote well-being and prevent mental and substance use disorder priority area. It has 2 focus areas. The first one is promote well-being, and the second one is mental and substance use disorders prevention. Each focus area has different goals, and for today, we will focus on goal 2.2, prevent opioid and other substance misuse and death. Next slide. So as I mentioned, there are several objectives under each goal, and under prevent opioid and other substance misuse and death, the first objective is to reduce overdose death by 7%. Second objective is to increase by 20% the rate of patient with opioid disorder receiving at least 1 buprenorphine prescription for addiction treatment. The third objective is reducing the opioid analgesics prescription for pain by 5%. And the last objective is to reduce all emergency department visits involving any opioid overdose by 5%. All those goals should be met by December 31st, 2024, which is the end of the current prevention agenda cycle. Next slide. So all these objectives from the prevention agenda, except reduce opioid analgesic, and you can see it highlighted in red, are aligned with the following goals from Healthy People 2030. It is aligned with SU 03, reduce drug overdose death, SUD 03, increase the rate of people with an opioid use disorder getting medication for addiction treatment, and the last goal here is SUD 04, reduce the rate of opioid-related emergency visits. Next slide. Next, we will discuss the prevention agenda process and stakeholders engagement. Next slide. Currently, we are planning for the next cycle of the prevention agenda for the year of 2025-2030. In general, the prevention agenda is updated by the New York State Public Health and Health Planning Council and the ad hoc committee at the request of the Department of Health. The ad hoc committee members are representing over 100 organizations across the state. This includes state agencies such as Office of Mental Health, New York State Office of Addiction Services and Support, Department of State, and Office of the Aging. We also have private organizations, community-based organizations, and academia representatives. The role of the ad hoc committee members is to provide feedback and on the overall approach and cross-cutting principles. This includes the vision, priorities, focus areas, interventions, objectives, and tracking indicators. The members also advise on how their organization can increase collaborative participation in a prevention agenda effort. Next slide. Local health departments and hospitals also play a crucial role in the planning and implementation of the prevention agenda. In this slide, I will go over some common activities conducted by local health departments and hospitals. First, community health assessment, or known as CHA. The CHA is the health assessment conducted to identify key health needs and issues through systematic comprehensive data collection and analysis. Second is the Community Health Improvement Plan, also known as the CHIP. Hospitals call them Community Service Plan or the CSPs. The CHIP and the CSPs are long-term systematic effort to address public health problems based on the results from the assessment or from the CHA. It is also helping LHDs or local health departments and hospitals to move from data to action to address health priorities identified in the assessment. In New York State, the CHA, the CHIP, and CSPs are updated every 3 years. Next slide. In the third cycle of the prevention agenda, New York State Department of Health required local health departments and hospitals to select one of the following options: 2 prevention agenda priorities and a minimum of 1 focus area for each priority, or 1 prevention agenda priority and at least 2 focus areas. And at least one of these priorities must address a disparity and promote health equity. Local health departments and hospitals within their county were encouraged to submit combined plans to reflect the need of their population they serve. However, also there were the option where they can submit a single plan for the hospitals or for the local health departments. Next. So local health departments and hospitals submitted their plan in December 2022. We received a total of 111 plans by 58 local health departments and 184 hospitals. A total of 37 combined plans were submitted for 42 local health departments and 74 hospitals. However, a total of 16 local health departments decided to submit a single plan without working with hospitals, and a total of 58 plans were submitted by 110 hospitals and hospital system. Next. Majority of the plans work to address health disparities in at least one of the selected priority area. It's worth noting that the New York State Department of Health definition of health equity and the meaning of health disparities are similar to Healthy People 2030 and focus on social determinants and avoidable inequalities. And going back to the plans, equity issues selected in the plans were socioeconomic status, race and ethnicity, healthcare access, geography, disabilities, age and gender. We noticed that urban counties were more likely to identify race and ethnicity as a disparity. On the other hand, rural and suburban counties were more likely to identify socioeconomic status as a disparity. However, most of the work plan is not clear on how to measure the impact on equity. Next slide. In this figure, you can see the top selected priorities. The orange bars are for hospitals and the blue bars for local health departments. Promote well-being and prevent mental and substance use disorder was selected by 90% of local health departments and 83% of the hospitals, which make it the top selected priority, followed by prevent chronic diseases and prevent communicable diseases and promote healthy and safe environment were the least selected priority areas. And you can see them to the right side of the chart. Next. In this figure, we are looking at the different goals under promote well-being and prevent mental and substance use disorder priority areas. The top selected goal was goal 2.2, which is prevent opioid and other substance misuse and death. It was selected by 66% of local health departments and 61% of hospitals. Next slide. For promoting well-being and preventing mental and substance use disorder, we have two core partners since 2013. The first one is the New York State Office of Mental Health, and the second one is the New York State Office of Alcoholism and Substance Abuse Services. This cross-sector partnership helps with identifying assets and resources, interventions, whether evidence-based or best practice interventions or strategies, and last, strategies that our partners will implement to advance the prevention agenda and improve the health of individuals of all ages. Next slide. Here's a screenshot from the Prevention Agenda website. We listed evidence-based intervention and resources for each goal. So you can see here in the screenshot, prevent opioid and other substance misuse and death goal. We have several interventions, including improving access and linkage to medication-assisted treatment, and other intervention focus on training and education to different populations, such as prescribers, pharmacists, and consumers. New York City is one of the examples I'm gonna give here. New York City Department of Health has selected multiple interventions, including but not limited to conducting annual public awareness campaign to raise awareness of the risks and consequences of opioids. The focus was on neighborhoods with population mostly affected or heavily impacted by opioid use. This include Bronx residents, older adults, and residents of very high poverty neighborhoods. Another intervention New York City is planning to implement is to increase community access to naloxone and maintaining distribution of at least 25,000 naloxone kits per quarter in neighborhoods with high overdose rates. Also, I'm gonna give an example of how hospitals are implementing those interventions from same jurisdiction, which is in New York City, the Mount Sinai Hospital in Mount Sinai, Queens. They're implementing a program called REACH. REACH stands for Respectful and Equitable Access to Comprehensive Healthcare. This program provides a patient-centered harm reduction approach to primary care for persons who use alcohol and other drugs and for individuals living with hepatitis C virus infection. The program offers different primary care services such as office-based buprenorphine treatment, stigma-free risk reduction counseling, hepatitis C treatment, and overdose response training, They also provide free opioid overdose prevention education and naloxone take-home kits. Next slide. Next slide. In tracking progress of the prevention agenda, we have a total of 99 statewide indicators. We monitor over time. So far, we have 29 of those indicators have met the target, and you can see them at the top side of this slide. The remaining 70% did not meet the target. The pie chart at the lower side of the slide break down the indicators to show more detail about the progress. So we have 33% of the indicators has improved, 41% remained unchanged, and only 24% of the indicators went the wrong direction and got worse. Next slide. In this figure, you can see the progress by priority area. For promote well-being and prevent mental and substance use disorder, 41% of the indicators has improved, 29% of the indicators did not change, and only 29% of the indicator got worse. And you can see the majority of, or most of the indicators really did not change or got worse, which means we are facing some challenges in this area. Next slide. In general, there are 3 indicators related to opioid prevention. Indicator number 64, which is overdose death. It hasn't moved in the wrong direction and got worse. The prevention agenda target is 14.3 deaths per 100,000 population. However, in 2022, the age-adjusted drug overdose death rate was estimated to be 21.2 per 100,000. The other 2 indicators, indicator number 65, which is buprenorphine prescription, and indicator number 66, opioid analgesic prescription, have improved and met the prevention agenda target. Next. In this figure, you can see the age-adjusted rate of buprenorphine prescription per 100,000. It was 427, which exceeded the prevention agenda target of 415 patients. More patients with opioid use disorder receive treatment, although the prevalence of opioid use likely decreased in New York State. And despite the impact of COVID-19 pandemic, New York State continued to make progress with increasing the rate of patients who received opioid treatment. Further, in response to the disruption in care during the pandemic, telehealth efforts were expanded to allow for initiating and continued prescribing the treatment for patients. Next slide. For New York State, excluding New York City, the age-adjusted rate of patients with at least one buprenorphine prescription have continued to increase through 2022, which means we also succeeded to meet the indicator outside of New York City and the rest of the state. Next slide. This figure shows the age-adjusted rate by county. Counties in Long Island, New York City, and Mid-Hudson Valley were among those with the lowest age-adjusted rate for patients who receive buprenorphine prescription. One possible explanation of the lower rates of the treatment or prescription among New York City is because New York City has historically had more availability of methadone treatment for opioid use disorder as compared to the rest of the state. Next slide. If you're interested in learning more about the prevention agenda indicators, the source of data or progress, I highly recommend that you visit the prevention agenda dashboard link. You find it here in the slide. In summary, during this prevention agenda cycle and after the COVID era, we have learned that social determinant of health greatly impacted health and health outcomes. Because of that, New York State Department of Health and stakeholders are discussing the possibility of integrating social determinants in the prevention agenda framework in the next cycle. Second, because the current prevention agenda framework has multiple focus area and multiple indicators, as you've seen, it is 99 indicators, it was challenging to align hospitals and local health departments' priorities. This challenge was prominent in large population counties with multiple big hospital systems. Our team is planning to focus and streamline the prevention agenda priorities and indicators for the next cycle. This will encourage the collaboration between local health departments and hospitals. And last, health outcomes are not only impacted by health factors. One main lesson we learned across all years, collaboration and partnership is a key. Collaboration with sister agencies such as Department of State, Office of Aging, and other agencies such as businesses, community-based organization is important to achieve health equity. Next slide. This work would not be possible without the wonderful team I'm working with. So big thank you to the Prevention Agenda team and for the dashboard team. Next. If you are interested to know more about the Prevention Agenda, feel free to contact us in the email on this slide. Now I will pass it to Carter Blakey. Thank you.
Great. Thank you, Zahara, for that excellent presentation, and also Paul and David for your presentations as well. I think we all learned a lot. So we do have some questions that have come through, and I'm going to kick off that Q&A session. But again, if you have other questions, please feel free to put them into the chat box there. So I have a question that I'm going to pose to all of our presenters, plus Andrew Geller and Ralph Hinson. So are there pressing, I guess, opportunities for you all that you would recommend to anyone who's working in the field of substance misuse? What key piece of advice or information can you share that would help them address substance misuse? So if you could all just kind of go around the horn, that would be great.
I'll start off. Thanks, Carter. So I think this generically applies for any issue of primary concern that an organization might be having, but particular to this subject. The objectives that we highlighted in today's webinar represent only some, but certainly not all of the Healthy People 2030 objectives that touch on the issue of substance misuse. So I'd recommend for those interested that they visit Healthy People 2030, our website, to browse our objectives, which are organized into a whole variety of topic areas, including drug and alcohol use. And you can find the current data on the objectives, as we've talked about, explore the data tools, including new disparities data tools, to see differences in health outcomes across populations, including race, ethnicity, sex, and income level, much of what David demonstrated earlier. You can also access many more evidence-based resources well beyond what we've alluded to here on that Healthy People website, all of which are focused on strategies proven to address substance use. The resources include interventions to address public health issues related to all sorts of specific population groups, as well as improve the health of all people. I mean, the end game for healthy people overall, obviously. But most importantly, they're meant to inspire action at the local level. So I strongly recommend seeking those resources out. And again, that website is healthypeople.gov. Pretty easy to remember.
Great. Thank you, Paul. So Andrew, would you have something to add to that?
Sure. So for those working to address prescription opioid misuse in the field, we'd suggest reviewing the comprehensive approach outlined in HHS's overdose prevention strategy. I give a link for that. In addition, given the association between long-term prescription opioid use and prescription opioid misuse, we also note the importance of CDC's clinical practice guideline for prescribing opioids for pain, which provides recommendations for clinicians providing pain care, including those prescribing opioids for outpatients aged 18 years or older. And this includes determining whether or not to initiate opioids for pain, selecting opioids and determining the dosages of opioids, deciding the duration of the initial opioid prescription and conducting follow-up, and assessing risk and addressing potential harms of opioid use.
Great, thank you. And then Ralph, I'll move this on over to you.
Yes, there are a number. First of all, I think the goal that has been established for reducing the percentage of alcohol impaired driving is quite reasonable. Since the early 1980s, the number of alcohol-related traffic deaths in the United States has been cut in half, saving hundreds of thousands of lives. The percentage of DWI, or driving while intoxicated deaths, has declined from about 50% down to now 31%. So changing it down to 28% or 28.6% is certainly an achievable objective. What does it take to be called an intoxicated driver? Driving at a blood alcohol level of 0.08, that's the equivalent for an average man of 5 or more drinks in a 2-hour period, or a woman 4 or more drinks in a 2-hour period. That's certainly far too much. It increases the fatal crash risk by at least 11-fold. Things that we can do to reduce alcohol impaired driving. First, we need to have collaborative efforts between federal agencies such as the National Highway Traffic Safety Administration, Centers for Disease Control and Prevention, and my agency, the National Institute on Alcohol Abuse and Alcoholism, and private citizens such as Mothers Against Drunk Driving. Specific steps would include lowering the legal blood alcohol limit from 0.08, which it is now in 48 states, to 0.05, which Utah has recently adopted. Recent studies suggest that doing that would reduce, we could prevent 1,100 to 1,700 traffic deaths a year. Another step might be to have mandatory ignition interlocks for all vehicles where people could not start their vehicle if their blood alcohol level was 0.08 or higher. Currently, only 35 states have that for repeat offenders, which are only a third of the account for a third of the drinking and driving deaths. Hopefully, we can get them installed in all new vehicles, but it'll take at least 10 years for that to take place. I think that we need to enhance high visibility enforcement through sobriety checkpoints and saturation patrols. Unfortunately, DWI arrests in the United States have declined from roughly 1 million a year to about 500,000 a year. Next, we could increase the number of states that have primary seatbelt laws, which means the police can stop a vehicle simply if somebody's not wearing a safety belt. And in states that have adopted that kind of law, the people who have been most likely to adopt belt use, which cuts the risk of fatal crash in half, is young drivers and drivers who drive after drinking. So that clearly would help. We could reduce drug-impaired driving. The risk of driving after marijuana use, for example, the most widely used substance other than alcohol, is not as great as the risk of driving with a blood alcohol level of 0.08, which we're calling drinking and drunk driving. But if you combine alcohol and marijuana or other drugs, then the risk becomes higher than using either substance alone. And then we could certainly enforce our underage drinking and driving laws. The greatest declines in alcohol-related traffic deaths over the last 3 decades have been among underage drinking. Raising the drinking age to 21 and making it illegal for people under 21 to drive after any drinking was largely responsible for that. The greatest declines in alcohol-related traffic deaths during those periods involved people who were under the age of 21. So if states could adopt all of these measures, there's every reason to believe that we could not only reach the 2030 goal with regard to alcohol impaired driving, but we could surpass it by a considerable degree.
Great, thank you so much, Ralph. And Zahara, was there anything you wanted to add to that? Either of the responses we've had so far?
Yes, so at the state level, I think we need to highlight that health is not the role only of the Department of Health. Every state agency has a health component to their mission, basically, and intersectorial partnership is really important, and we have seen it here in New York, where we partnered with Office of Mental Health, Office of Aging, because we are addressing different populations, and each state agency, our commissioner basically call them the Department of Social Determinant of Health. Department of Transportation, they provide transportation. Department of State, they basically make sure we have greenery space, exercising spaces. So all of them, they have a mission for health, and you cannot really reduce the disparities without working with them. So the key message here is partnership with state agencies and the community organization. They serve people. They are the one who knows the people. They are the one who they understand the barriers people go through. So it is always important to have them at the table to discuss the barriers, to understand the how could you basically put all the resources and address those issues. So again, the collaboration and partnership with everyone is important in the planning and implementation, not just the planning phase.
Yes, this is Ralph Hinkson. If I could add to that, in the area of impaired driving, Mothers Against Drunk Driving has been an important citizen activist group that's helped to pass over 2,000 pieces of legislation to reduce alcohol impaired driving. And what they did, what they are very skilled at, is putting a personal face on the problem and telling the stories of people who had been hurt by drinking drivers. It's important to remember that nearly half of the people who die in traffic crashes involving an alcohol impaired driver are people other than the alcohol impaired driving. So when we think about public health progress that we've made in my generation, reducing smoking was one of the great areas where we made improvement. And the tipping point there was when people realized that the smokers weren't just harming themselves, they were harming other people. Well, the same is true with drinking and driving. Alcohol impaired drivers don't only increase their own fatal crash risk, but they increase the likelihood that other people who have not been driving after drinking will be killed in these types of crashes. So we need to protect innocent people from the behavior of people who drive above the legal blood alcohol limit. And if we lower it down to 0.05 and do some of the other things that I talked about, we can certainly reduce these deaths, not only to the drinking and drivers, but to other people as well.
Great, thank you so much. And we are just about out of time here, but I'd like to encourage people quickly to look into the Q&A, and some of the questions posed have been answered, but we do have a couple of others that have not had an answer yet. So I'm going to.
I can try to field one of these.
Okay, yeah.
There's a broad question asking whether every state in the United States is required to have a similar 2030 plan. I gather that's in reference to the presentation that Zara gave in New York State. And the answer to that is that the onus is very much on the state, or whatever the level of jurisdiction is or the organization is, to determine what their priorities are, what their focus areas are, and how much they want to adopt a plan framed off of the healthy people objectives. You know, we see the utility of healthy people everywhere, frankly, in not just state and local governments, and obviously at the federal level, but across organizations of every ilk, to address whatever their targeted issues are, and in the populations that they serve. So it's highly variable, but there is similar representation of the utility of healthy people as New York State has demonstrated in many, many places across the country.
Great, thank you so much, Paul.
Mm-hmm.
Yeah, and healthy people, we do put it out there for states, communities, whomever, to use as a full menu of options that to choose from as you develop your own plans. So with that, we have actually hit the top of the hour. And I think we could have probably gone on for another half hour with all the questions that have come in and all the great ideas that have been presented by our different presenters. So thank you all. We do appreciate your participation, and do sign up on the Healthy People listserv to find out more about our upcoming webinars, and hope you can join us then. Bye-bye.
Take care. Have a good afternoon, everyone.